It is inability to touch the opposite shoulder. That is Dugas test. Now, what do you mean by this term, inability to touch the opposite shoulder? Just imagine if the patient is having anterior dislocation of the shoulder and you ask the patient to touch the opposite shoulder, he won't be able to touch the opposite shoulder. This is Dugas. But in reality, what is Dugas test is inability to bring the elbow in the midline. The patient won't be able to bring the elbow in the midline. It is almost impossible for a patient who is having anterior dislocation of the shoulder. All right. But as far as your examination is concerned, and at this just post-graduation level, this is what you have to remember: inability to touch the opposite shoulder. Second is Hamilton ruler test. Now, just try to have a basic understanding of what is Hamilton ruler test. You see, imagine this is the acromion process. You know, there is a bony prominence which you can palpate in your own shoulder. That is a bony prominence in the uppermost aspect or the upper lateralmost aspect of the arm. That is acromion process. So this is acromion process. And the other bony prominence on the lateral aspect of the elbow is the lateral epicondyle. So this is lateral epicondyle. Now, if you try to put a rigid ruler and try to connect both these 2 points, it is impossible. Using a rigid ruler, it is impossible to connect both these 2 points simultaneously, to touch both these 2 points simultaneously. It is impossible in a normal shoulder. But in case of anteriorly dislocated shoulder, because the loss of deltoid will be there will be no bony support. It has provided or it has drifted medially. The acromion is getting more prominent and you would be able to touch both these 2 bony prominences simultaneously by a rigid ruler. That is known as Hamilton ruler test positive. Alright. So here the acromion is getting more pronounced. Here the lateral epicondyle, and if you try to touch them by placement of a rigid ruler side by side, touching both these 2 prominences is a possibility in case of anterior dislocation of the shoulder. That is Hamilton ruler test. And Bryant's test. Now, what is basically the Callaway's, Bryant and the Callaway's test? In case of Callaway's test, first of all, we are going to have a discussion on Callaway's. Now, what happens in case of Callaway's test? That the head of the humerus, because it has moved anteriorly, the anteroposterior diameter of the axilla, the anteroposterior diameter of the axilla will be increased. So, this is what is known as Callaway's test. Just try to understand. This is the anterior point of the axilla and this is the posterior point of the axilla, and the difference in between the two is the anteroposterior diameter of the axilla. Alright. In case there is an anteriorly dislocated shoulder, then while measuring this anteroposterior diameter, you also will measure the dislocated head of the humerus and it will be increased. So this is what is known as Callaway's test, where there will be an increased anteroposterior diameter of axilla. Alright. So this is what the Callaway's test is. Next, as far as the attitude, because majority of your questions are asked out of the attitudes, alright, not from the clinical features in direct, but the attitude. When you look at the patient, you look at the abnormal position in which it is held, you will decide that whether it is anterior and posterior just by looking at this as at the abnormal position in which the arm is held. Alright. So what is the attitude or that abnormal position of the arm? The patient will be coming to you in emergency after sustaining anterior dislocation. Now just try to understand. This is anterior dislocation. After getting anteriorly dislocated, the head of the humerus will migrate medially. Alright. Because of this medial migration, the lateral musculature will be more contracted, thereby lifting the arm into abduction. So one of the attitude is abduction. Second, when it has moved anteriorly, the posterior rotators will be more stretched. Alright, because if it moves anteriorly, the posterior rotators will be more stretched. And following stretching, there will be more rebound contraction, as a result of which it will be forcing the arm to move into external rotation. So there will be external rotation. So abduction and external rotation. And finally, when it is anteriorly dislocated, alright, the shoulder is anteriorly dislocated, then the condition will be extremely painful for the patient. And how the patient will manage, he will support the affected arm with the elbow. This is how the patient will support. And in order to support the elbow, it has to be kept in front of the body. And in front of the body, the movement is flexion. So flexion, abduction and external rotation is the attitude the patient would be coming to you, or patient would be coming to you after sustaining anterior dislocation of the shoulder. Do remember this: flexion, abduction and external rotation of the arm. As far as diagnosis for this anterior dislocation is concerned, it is entirely clinical. You have to diagnose the condition clinically. Once you have made the diagnosis, you will just get the x-rays done in order to identify that whether the shoulder joint is dislocated or not, and for MLC purposes more commonly. Otherwise, the diagnosis is already made on the clinical examination. So on x-rays, what you tend to see is that there will be a head of the humerus out of the glenoid. Simple. There will be a dislocation and the arm will be held in abduction. So this is how you will diagnose the condition, that is anterior dislocation of the shoulder. Now, as far as the management is concerned, the principle of the management is closed reduction. You have to reduce it. All right. Closed reduction. Now, there are several methods of achieving this closed reduction. The most commonly used method is the Kocher's method. This is most commonly used method. Now, what are the steps in Kocher's method? First, the traction. As you can very clearly see from this pictorial depiction, that the examiner, or the surgeon is trying to pull the arm while the attendant or the assistant is giving a counter traction. So first you are applying traction, then you will go into abduction, then adduction and internal rotation. So traction, then you further abduct the arm, then go for adduction of the arm and then internal rotation. And this is how it will be reduced. So Kocher's is the most commonly used method for the purpose of reduction in anterior dislocation of the shoulder. Now, despite it is most commonly used, it is having the highest incidence of neurovascular injury. Now, this is the method which is having the highest incidence of neurovascular injury. Now, you will say that why, if it is having the highest possibilities or incidences of neurovascular injury, why is it considered to be the most common method? Actually, it is reciprocative. It is having highest chances of neurovascular injury because it is the most commonly used method. All right. Other method like is Hippocrate method, Stimson's method and Prakash method, they are less commonly used. Thereby, the possibility of neurovascular injury or the incidence of neurovascular injury subsides because it is we are not using it. Once the method which is used is going to have the possibility of the complications related to the management. Hopefully, you have understood what I am trying to say. That it is not like that the Kocher's method is at a disadvantage of having the highest chances. No, it is because it is the method which is most commonly performed. So, if at all the neurovascular injury has to happen, it will happen with the method which you are performing to reduce the shoulder joint. All right. And that is Kocher's method. Other method is Hippocrate's method. Now, in Hippocrate's method, what you are performing is you put your foot in the axilla of the patient while you are applying the traction. So, while applying the traction, you will maneuver the head of the humerus back into the glenoid. That is Hippocrate's method. And finally, the Stimson's method. Now, in Stimson's method, what is being done? It is a self-reductive method. That means spontaneous reduce. It is a method for, Stimson's is actually a method for spontaneous reduction using gravitational assist. All right, using gravity. So what you do, as you can very clearly see in the picture, that the patient is made to lie prone on the couch with the affected limb made to dangle by the side of the couch. There are weights which are tied on to that affected limb and you wait and watch for spontaneous reduction. All right, this is a Stimson's method. So out of these three, the Kocher's is the most commonly used method. This is the reason why it is having the highest possibilities of injury to the nerves and vessels. But this Hippocrate's method and this Stimson's method is less commonly used. All right, so these are the methods for reduction of anterior dislocation of the shoulder joint.